بسم الله الرحمن الرحيم. الحمد لله رب العالمين، الرحمن الرحيم، مالك يوم الدين. إياك نعبد وإياك نستعين، اهدنا الصراط المستقيم، صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Shukran. I would like to welcome all of you to today's X-ray interpretation session. This will also be our last session of the academic year, and our presenter today will be Dr. Muhidin Shariff, who used to be an undergraduate here at UN, and he has a keen interest in radiological research. He is currently a final year resident in radiology here at University of Nairobi. Welcome, Dr. Ari. You can begin.
Thank you so much. It's good to have all of you here, and I'll make it as simple as possible so that at the end of the meeting, we can all be comfortable to see an X-ray and be comfortable with it. I don't know if they still ask if they still have X-ray stations in OSCE examination. So we'll just try to make it simple so that we all benefit. Any question you have, you can raise your hand. And anyway you don't understand, you can interject and seek further clarification. And I hope we all benefit from this, inshallah. Bismillah. Maybe the host can enable me to share my screen. Am I audible?
Yes, we can hear you.
Yeah, maybe the host can enable me to share on my screen.
Sure, just a minute. I think you can now share.
Yeah. So, yeah, you can see on slide share. Yeah?
Yes.
So today we'll just go through the basics of chest X-ray interpretation. And my names are Dr. Muhidin. So we'll just introduce and go through the basics, and we can then review some common pathologies. I request that we make the meeting as interactive as possible so that it's beneficial to all. So chest radiograph or chest X-ray, it's one of the most frequently performed radiological investigations.
I think it's just X-rays in general. Common indications, respiratory disease, cardiac pneumothorax. I guess if you're not doing anything, you can just
Well, so it's the most commonly performed radiological investigation that you will come across, and is a basic investigation tool that we should be comfortable to interpret after qualifying. So most common indications for chest radiographs are patients with respiratory diseases, cardiac diseases, patients who have pneumothorax, pneumoperitoneum, and trauma patients. And radiologically, there are so many modalities of imaging, and it's always good to know what is indicated for what, so that at the end of the day, you save the patient the cost of so many images. If it's something, a disease that you think can be diagnosed with a chest radiograph, it's good to send for a chest radiograph. If you find that maybe whatever investigation you want can be diagnosed with an ultrasound, please just tool the examination to the patient indication. That's why it's always good to have a reason why you seek for investigation for every condition. So chest X-ray review is a key competency for medical students, junior doctors, and all allied health professionals. There are so many methods of reading a chest radiograph. Some prefer the in-out method, where you come from the middle of the radiograph as you progress to outside, or from the outside to the inside. But I've simplified it to ABCDE method, and that way you'll be able to systematically review the radiograph. And it's a very it's an easy way of remembering key structures in the chest radiograph. So A stands for the airways. So we usually assess at the top, in the middle, to assess the airways. So you look at the trachea, you try to trace the trachea up to the carina, and thing you look for in the trachea is it straight, and is it in the midline, or it's shifted, or it's narrowed. And then you trace the main bronchi. The airways, the chest radiograph is able to visualize the airways up to the main radiograph, unless there are diseases that, dilate the airways, like bronchiectasis and those things. But a normal radiograph, a routine radiograph, you'll be able to see up to the main bronchi. Segmental and the bronchioles, unless it's pathological, you won't be able to see them. So you trace the main bronchi, and you want to see, is the carina widened? That means you should familiarize yourself with the angle of the carina. It's usually an acute angle. And then you want to see the main bronchi narrowed or cut off. Cut off is abrupt disappearance. And you always have two sides of the radiograph. If you feel like you can see something here and you're not sure, always compare it to the other side. Then along the airway, you want to see if there is any inhaled foreign body. So this is a frontal chest radiograph. I just focused on the airway so that at least we can follow it. We can follow it in a systematic way. So as you're looking at your chest radiograph, you will be able to trace the trachea. In a radiograph generally, there are different levels of, if I put in a common language, there are different levels of tissue density. So air appears usually dark on a radiograph, followed by the subcutaneous tissue, followed by the blood vessels, followed by the bones. The bones is the brightest, and the air is the darkest. So it's that way you are able to see tissue differentiated in 2D. So the trachea is a centralized structure that contains air. So you're supposed to see as it goes down up to the carina. Carina is the branching of the trachea into the main bronchi. So you follow it. Keep it simple. Just look, is it narrow? Is it in the midline? If it's narrow, then you will think this is not a normal trachea. So what might be compressing it? What might be narrowing it? If it's shifted, you want to know what might be pushing it away, what might be pulling it to that side. So you follow this dotted line. I tried to annotate the image. So the dotted line, you can see it goes to the right main bronchus, and the right main bronchus is usually more vertical and it's wider than the left main bronchus. That's why if a foreign body is inhaled, it goes more to the right side than the left side. And then this is the angle of the carina. It's usually an acute angle. Usually it shouldn't be obtuse, but then as we review, we'll come to realize what makes it obtuse, what makes it, obliterates it. So you check the trachea, make sure it's in the midline and there's no narrowing. Simple. You check the carina, is it too wide? Then if it's too wide, then you know there's something wrong. Then you check the bronchi, is there any foreign body within the bronchi? A foreign body will look bright, and then the air will outline it, so you'll be able to pick it up, unless it's something that is inhaled that is not bright. There's so many things that children inhale. Mostly it's the children that inhale these things, and there's so many things that you look at that will also tell you that this might be likely a foreign body. So I tried to put something. Remember, just picture your head that the trachea should be in the central. So we have a radiograph here, and you want to see. Just focus on the airway. Don't look at any other thing. We'll come back to that. So if you look at this trachea, it's not midline. It's shifted to this side. So that means there's something that is pushing it. So that is one of the first thing you'll pick it up if you're looking at the airway. Then you have, this is another frontal radiograph of a different patient. So you can see that this trachea, you can see this linear airfield structure that is here. Ideally, it should be in the middle. So you feel that there is shifted to the right side. Then you ask what is pulling it or what is pushing it. Okay. We'll come back to this, what might be causing this and this. Okay. So for this frontal radiograph, so that we save on time, this is a patient who had a pneumothorax. So how you can identify a pneumothorax is, a pneumo is air. So in a normal chest radiograph, you can see that there is something called bronchovascular markings. You can see, within the lungs, you can be able to identify some vasculature within it. But when you come to this side, there is an area that is occupied by air and there is no vascular marking within it. And then you'll be able to see that this is the lung that has collapsed. It's pushed. This is the whole lung. So this is a patient who had a pneumothorax that was pushing the trachea away. So this is a case of tension pneumothorax. There are two types of pneumothorax. There is spontaneous pneumothorax and tension pneumothorax. I know tension pneumothorax may be associated with trauma, but that's not the case all the time. So tension means the pleural space is filled by air and pushing the mediastinum to the other side. That makes it a tension. If there was this pneumothorax, but the trachea is central, that will make it a spontaneous pneumothorax. And then the causes are also different. For this one, this is a frontal radiograph. You can see that this trachea is more shifted to the right. Then your question is, what is either pushing it or pulling it? So if you see this lung, it has the same, this lung has reduced volume as compared to this. You can just see this is the part of the lung that is aerated. Then there is this dense opacification in the upper lobe. Then you want to see, is this a pneumonic process? Is this, a lung collapse? Because they will all appear opacified. Then there are certain things that will help you identify what is pneumonia, what is atelectasis. A pneumonic process, when we go to as we go along it, you'll see something called an air bronchogram. If you don't see an air bronchogram, a lung collapse. If you see these ribs, you see the spacing between the ribs. Then compare with the spacing here and here. You see that there is a lot of rib crowding here. When a lung collapses, the ribs get crowded. So that is an indirect sign that can also help you. So I hope you'll be able to remember. And in any radiograph, whenever you are in an exam situation, don't forget to mention, those lines, the external tubing. Like this one is an NG tube, it's leading to the stomach. You might have an endotracheal tube. All those things are essential in mentioning in an exam setting. So this is another patient. This was a case I wanted to show you how a carina, when it's played, how a carina splayed looks like. Just let me go back. You see how nicely this carina is obtuse? Then when you come back here, you see this is the right main process, this is the left. If you imaginary angle, this will make it an obtuse angle. So this is a patient, I think these are common things that you might be asked. This is a patient who had a rheumatic heart disease. There is a double cardiac shadow. You see this, okay, I might use this. So this is how the right, let me go actually back to a normal one. So you see, this is the right heart border. This is the left heart border. Usually a third of the heart is on the right, two-thirds is on the left. And the only heart border that you should see should be one. If you see a double heart, you see this dense border that is here as opposed to the normal border. So this was a case of a left atrial enlargement that was causing splaying of carina. This patient underwent surgery. He had these are sternotomy wires, and this is a replaced mitral valve. This is how a replaced mitral valve looks. And he had some pulmonary congestion. You can see that. Okay, when you go to the vasculature, just remember this image, and in case I forget to come back to it, please remind me. So we go to B for breathing. So you look at the lungs. We looked at the airway. Now let's look at the lungs and the pleura. So you want to see, is this lung well expanded? And are they, the lung volumes on both sides, are they symmetrical? A well-expanded lung, you should be able to count 10 ribs posteriorly and at least 6 ribs anteriorly. And then you want to find out the lung volumes. Are they symmetrical, or one is larger than the other, or one is smaller than the other, whichever dimension you want to take. Then you assess the lung zones. There is the apical lung zone, the upper, the middle, and the lower lung zone. And then you see, always compare. You have a left and a right side. Very rarely you will find there is a pathology that is affecting the same lung zones on both sides that will appear symmetrical. Very rarely will pathology appear like that. And then you want to see, are there changes between the sides? Are there changes in density? And then you want to look for lung vascular markings. You want to see, is the branching uniform, or one side is more dominant than the other? And then you want to check behind the heart, retrocardiac region, and behind the diaphragm, the retrocardiac vessels. And then you want to see, are there any lines in the periphery? These are patients who have, most of the lines you'll see in the periphery are those Cali B, Cali A and C lines. Then you want to assess the costophrenic angle. And then you want to trace the hemidiaphragm into the vertebra. Make sure you see the whole diaphragm. A chest radiograph can have so many pathologies. A hiatus hernia can appear in a chest radiograph and you can be able to diagnose a hiatus hernia on a chest radiograph. That's why it's important to follow the diaphragm into the vertebra. And then you trace the cardiac border. Are you able to outline very well the right and the left? And can you be able to see the descending aorta? I tried to annotate some image. So here you want to see the lung volumes. Okay, are they symmetrical? When a radiograph is taken, there are different views of the radiograph, different orientations. You have an AP, you have a PA, you have supine. Supine, AP more or less look the same. You see, when a PA is taken, that means the X-rays are coming from the back. So what you see first is the posterior ribs. And the posterior ribs usually appear more horizontal. And always make sure you follow all the ribs. You see, this rib is one. It has an anterior part and a posterior part. It's just the same rib that is going round. So make sure you're able to see, you're able to follow all the ribs. Like this is the second rib that has come like this. This is the third rib that has come like this. This is the fourth rib that has come like this. That way you'll never be able to miss even a rib fracture. So you want to see the lung volumes. Are they symmetrical? You go to the lung zones. The border is above the second rib, the apical, second to fourth anterior ribs. Above the second anterior rib is the apical zone. Between the second and fourth anterior rib is the upper. Fourth to sixth is the middle. Below the sixth is lower. So you want to see, always compare both sides. Is there difference in density? Is there difference in lung markings? Is there difference, in opacification, if there is any? Then you want to see the age of the lung. Sometimes you can have pleural thickening or calcification, or even a layered pleural fluid in case of empyema-thoracis. You want to see the costophrenic angles. Make sure you follow the diaphragm up to the vertebra and you're able to outline it very well. Look behind the heart. Normally, you should be able to see some vessels behind the heart. If you're not able to see some vessels behind the heart, then you ask, what is obscuring those vessels? Then look at the cardiac margins. Okay? This is an example. These are patients. Okay, is there a volunteer who can just, just say what they can see? From the brief thing we have discussed. It's okay to be wrong, don't worry. It's a common thing in the, in those OSCE examinations. That's why I picked the most common things that they can bring. Any volunteer?
Yes, actually it shows that the mediastinum has shifted towards the right, yeah? I don't, maybe this is pleural fissure, that's what I see.
Okay, the mediastinum, what makes you think that the mediastinum has shifted? Like what structure? Because the mediastinum has the heart, has the airways.
The trachea has shifted towards the right.
Okay. So,
Okay.
this trachea, sorry?
Dr. Is there a loss of costophrenic angle on the left side? Then there is a meniscus margin on the, it looks like a fluid. Then there is a shift of a trachea to the right. So I think it is a pleural fissure.
Okay, thank you so much. Both of you picked, one thing, two things, we add all together. So the trachea is still central, not yet shifted. This is the main bronchus, the right main bronchus. This is the trachea. So it's still central, but you can see this costophrenic angle very clearly. We can see the right heart border, we can see this lung. This lung has reduced volume as compared. A normal lung is aerated and it has air within it. So this is the part of the lung that you're able to see. So there is reduced lung volume on the side. That is one. Two, you lost this costophrenic angle. There are many things that make you lose costophrenic angle. Let's say if this lung has collapsed on this side, it will still be as dense as this. But then you want to know this white, opacification. Is it fluid? Is it collapsed? Then you can see one of our colleagues said there's a meniscal sign. As you see, these lung margins are well outlined, but this one you can see there is fluid that's layering here and layering here. So that means there is meniscus. So this was a case of a pleural effusion. Next, who can try this one? It's okay to be wrong, you know. Just say what you think, and then we can see how we can.
Hello.
Yes, Dr.
So for me, I feel like the dark area, which represents air, is a lot.
Sorry?
So like the dark area is a lot representing air. So maybe it's like a pneumothorax. And the markings, the bronchovascular markings, they're not going all the way to the edges where they're supposed to go. Yeah, but the trachea is like midline, and the heart is also in the midline. Yeah.
Thank you, Daktari. As we go, as we go to A, B, C, D, so now we have reached A, B. For systematic review, just look at the trachea. You say the trachea is central. You can be able to follow it to the main bronchi. The carina is still acute. There is no widening. There is no foreign body. That is the airway. We came to the breathing. How many ribs can you count anteriorly? Let's count. 1, 2, 3, 4, 5, 6, 7. How many ribs can you count posteriorly? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So in a normal expanded lung, you are able to see 10 posterior ribs and at least the 6th rib to cross the diaphragm. So this is more than expanded. Okay? So that at least I'm trying to make sense of the routine way so that at least it fixes. So these lungs have expanded. What else will show you the lungs have expanded? If you look at this diaphragm, it's well, dome-shaped. When you have a hyperinflated lung, the diaphragm will flatten. You see the flattening? Normally, the right hemidiaphragm is above the left. Then you see these ones are at the same level and they are flattened. Daktari talked about the vascular markings. We can be able to see, up to the periphery, we can be able to see still some lung markings. So that means there is no air within the pleural space. Neither is there reduced bronchovascular markings. There are different normal variation in human beings. This is the horizontal fissure. Certain percentage of people, the horizontal fissure usually appears on the chest radiograph. So please don't confuse with abnormal, in those CADI B lines and CADI C lines. Some percentage of the human beings have the horizontal fissure on the right visible. So this is a horizontal fissure. So this was a case of hyperinflated lung. Someone else to try? I just want to get the routine of, we have reached up to the airway breathing. So there is no trick, just focus on those two. Just describe what you have seen, what you have gone through now. and then there is no addition to it. I just made sure that the image I put just focuses on the airway and the breathing. As we go along, we'll add the circulation, we'll add the deformity and those things. Someone else to describe? Or we save on time, I just describe. And then I also picked, the most common things that you might be asked. Okay, let's go through together. Same way, you have the airway here. The trachea is central, you can follow it to the bronchi. The carina is still acute. There is no widening, so the airway is okay. You go to the breathing. The lung volumes appear normal. You can be able to count 1, 2, 3, 4, 5, 6. The sixth rib is crossing the diaphragm here. 1, 2, 3, 4, 5, 6. The sixth rib is also crossing. You can be able to count 1, 2, 3, 4, 5, 6, 7, 8, 9 posterior ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9. More or less, not so significant. So the lung volumes are okay. Then you want to look at the lung zones. Then you have this, if you compare on this side, you have this opacity. Then you have this linear, linear air outlining within the opacity. That's what is known as an air bronchogram. You have an opacity that you have a branching linear within the opacity. That is what is called air bronchogram. So this was a case of lobar pneumonia with air bronchogram within it. So this is another radiograph. I'm just trying to put some sense what we just discussed. Systematic, go to the airway, the trachea, follow to the main bronchi, the carina, then look at the lung volumes. Are they symmetrical? Yeah, they're symmetrical. Are they well expanded? Then you look at any, abnormal opacity. This one had this well-rounded opacity in the left middle lung zone. You look at the costophrenic angles, they are sharp. So this was a case of a patient who had a lung mass. Okay. So now I think this is the easiest you can describe. You can see that this trachea is a bit shifted this way. If you compare this side of the mediastinum and this side, they're more or less like 50-50. Should be a third to third. So there is some mediastinal shift. You can not be able to outline the vascular markings here, and you have a lung that is collapsed. So this was a case of a pneumothorax. So we go to the circulation. In the circulation, you look at the heart and the vessels, both the systemic and the pulmonary. The systemic, you want to see the aorta, both the aortic nerve ball and the descending aorta. You want to check the cardiac position. Normally, a third is on the right, 2/3 is on the left. You want to assess the cardiac size, and you want to know the cardiothoracic ratio. You want to check the position and size of the aortic arch, especially in pediatrics, in children who have congenital heart disease. The position of the aortic arch is important. You want to check the width of the upper mediastinum. Again, most important in pediatrics. Some congenital heart diseases have narrowed mediastinum. Some have widened mediastinum. And then you look at the hilar vessels. You want to see, are you able to see the hilar vessels clearly, or they obstruct, or there is something that not obstructed, they are obscured. Then you want to see, is the right and the left hilar more or less the same height? The left can be a bit high, but not so high. And then you want to see, is the hilar point preserved? The hilar point is where, the vessels are coming together. So just concentrate on the circulation. I try to annotate some image. So this is the heart. A third is on the right, 2/3 is on the left. The cardiac borders are well outlined. This is how you calculate cardiothoracic ratio. You see the cardiac size from the right heart border to the left heart border. Then you take the maximum, the maximum thoracic ratio. Ideally, it should be 55, both on AP and PA. In children can go, some debate up to 60, but 55 is the maximum that you can say with confidence that it's not cardiomegaly. Then you want to see the aortic arc. This called the aortic knuckle, and it should be on the left. Once you see this on the right side, then you know definitely there's something wrong. Then this is the pulmonary bay, where the pulmonary trunk occupies. Then these are the hilar vessels, the green image. And they usually, the hilar should be obtuse angle. And then you want to see behind the heart always, do you see vessels? If you cannot see the vessels behind the heart, then you want to ask what is wrong, what's going on behind the heart. So this is a patient. Who can describe this, please? Just briefly, just focus on the circulation. Leave about the trachea, the airway. There is nothing wrong with those ones. Just focus on the circulation, the heart, and the pulmonary vasculature. Anyone? Any volunteer?
The position
This
of the
was
heart.
an incidental finding. So just describe.
The position of heart has changed. So it is dextrocardia.
So yeah, this a patient who was dextrocardiac. It was just found incidentally. He was asymptomatic. Like 2/3 of the heart is on the left. But then, normally there is dextrocardia, there is situs inversus, situs solitus. So you want to be confident that this is not situs inversus. Situs inversus means there is mirror imaging of everything. So this is the heart, but you can see the liver is on the right. You can see the gastric bubble. So it's just the heart that is affected. So it's a dextrocardia. If you have the liver on the left, the gastric bubble on the right, then it's situs inversus, and it will not be gastrocardiac. That means everything is shifted. Someone else? Okay, this might be a bit under too much. So you can see that this aorta, you can follow the descending aorta up to here. This is the aortic shadow. So this is a patient who had aortic aneurysm. And some patients who have hypertension, there is something called aortic unfolding, which can also appear like this. Always look at the heart borders. The right should have one. This patient had a double heart border. So he also had left atrial enlargement. The carina had splayed, so he also had a left atrial enlargement. So then we go to disability. Disability, you look at the bones. We have looked at the airway, we have looked at the lungs, we have looked at the heart, then you look at the bones. Then, as I said, just trace each and posterior anterior rib on both sides. Then you want to see, is there any fracture or an abnormal rib? Please make sure, don't focus on the chest, focus on other structures. The thoracic cage is big. You have a scapula, you have the clavicles, you have the shoulders. Make sure you don't miss a clavicular fracture. Make sure you don't able to miss a shoulder fracture on a chest X-ray. Okay. Then the vertebra, here and there, unless you have a lateral radiograph. So this is a patient who had multiple rib fractures. You see on the right, it's smooth. you're able to see, you're able to follow the ribs from posterior to anterior very nicely. Then as you come here, this is the first rib, looks okay. The second rib, you can see, you cannot follow it up to here. Then there is some breakage there. You can see the third rib, some break there. The fourth rib, there is a break here. It's not a smooth cortex. You can see there is a breakage, and then you follow it again, there is a breakage there. The fifth one, you follow it, there is a break here. These are the most obvious ones. So these are patients who had rib fractures. If this was a just radiograph, someone will have said it's normal if you didn't see the clavicular fractures. These are patients who had bilateral clavicular fractures. So other things that you need to look, you need to see the orientation. Is it PA, AP? I know it's a big thing. Just show you what you need. These are PA radiographs. You can see how the scapula has been relieved very nicely from the lung fields. You can be able to see the lung fields. Gastric bubbles depends on whether the person has eaten, not eaten. Not eaten means this person has air within the gas. If he has eaten, unfortunately, you won't be able to see the gastric bubble. So use the scapula and then use the ribs. If it's a PA, you'll see that, the posterior ribs are more prominent. The posterior ribs are usually horizontal. And if it's AP, you'll see that the anterior ribs are more prominent. What I mean is, you see this is a child. You can see this scapula, the way it's so lifted from the lung fields as opposed to. And then the heart looks a bit magnified. You see, this was an AP, this was a PA, but you can see the gastric bubble here. But mostly, to be confident, you just use the scapula, because when they're doing the PA radiograph, the patient has to have that so the scapulas are usually widely separated. Penetration, I'll show you an image of what a well-exposed look like, unexposed and overexposed. Rotation, how you check rotation, not the trachea. You don't use the trachea to check the rotation. You see these lines within, those are spinous processes. They're behind the trachea. So you want to see the spinous process, are they equidistant from the clavicle? So if they're equidistant, there is no rotation. If they're not equidistant, there is rotation. Okay? Please don't use the trachea, because sometimes it might be confusing. Normally, when the trachea comes down, it shifts to the right slightly before it comes to the central. So it might confuse you. So just use the spinous process, and you want to see if they're equidistant. Yeah. Or if you're not sure, just check the clavicular ends. If someone is rotated, one will, come down, shift here. So these are cases underexposed. Underexposed means, when an X-ray, someone is X-ray, it has to go through tissues. So when you have an underexposure, the bones will appear very bright because the bones will absorb. And then when you have overexposed X-ray, the lungs will appear very dark. And then the vascular markings, will not be as clear to the periphery as you like. In a normal exposed lung, there should be balance between the two, but ideally you should be able to see the intervertebral discs behind the heart. Okay. All right. I think that's all I had for tonight.
Thank you. There are some questions on the chat box. I'll read them out to you. First, someone is asking if you could repeat on the pneumothorax. You are muted, Daktari.
Okay. Sorry for that. So I was telling you, in all imaging, always look at both sides. That's why even when you're imaging the extremities, you write your request, 2 views, you write AB lateral. You're supposed, if it's a joint, always look at 2 joints, because sometimes there are normal variations among the human beings. So you don't have to call it a pathology when it's a normal variant. So if you check this lung, you're able to see lung markings or bronchovascular markings all the way to the pleura. Pleura is not ideally visualized on radiograph unless it's thickened. So when you have no lung markings in the periphery, and usually have, you'll see some outline of a lung, unless the pneumothorax is so small, which will be, very like, but still you'll see a thin outlining. Like you see, this is air that is occupying the pleural space. Then you have this lung that is compressed, the lung is usually small until it's expanded by air within it. If there's something compressing it, it collapses inwards. So this is the left lung here. This patient had a tension pneumothorax. You see, this mediastinum is shifted. The whole of the heart, the trachea is shifted to the right side. So this is a case of tension pneumothorax. Then sometimes you can have a pneumothorax which is not tension. You call it a spontaneous pneumothorax. Okay, that means there is no mediastinal shift. If let's say this heart was its normal shape, normal station, the trachea was central, but still you have air in the pleural space. Let me see if the other one, I think the other one is also, yeah, this one is not tension. Thank you. This is not tension. You see the heart, it's in its normal, position. The trachea, slightly shifted, but still central, not shifted actually. Then you can see there is no lung markings in the periphery. The most important thing, don't look at the shift. Look, is there lung markings in the periphery? If there are no lung markings, try to look for a collapsed lung. Like this lung is collapsed here. You see, it's outlined by air. Then that way you can be able to confidently call out a pneumothorax that is not tension. If you're not sure, in an exam setting, just say a pneumothorax instead of specifying tension or what, unless you're asked, is it tension or spontaneous, whichever. Thank you. Let's see, we have another question. So how do you count ribs anteriorly? Could you go back to the X-ray mitral valve replacement? Silhouette sign, okay. Could you explain me more on the Kali lines? Okay, let me just go through one by one. How you calculate the ribs and start with that one. The ribs anterior, if you follow my pointer, you see there is a rib that is coming that way. That's an anterior rib. But anyway, this rib is just the same rib. One comes, you see, this is the vertebra. Normally, the rib is attached to the transverse processes of the thoracic vertebra. So you're able to see from the transverse process, this is the posterior part of the rib. It curves to become the anterior. This is the posterior part of the rib, comes to become the anterior. This is the posterior part of the rib, comes to become the anterior. This is the posterior part of the rib. You follow it, comes to become the anterior. This one comes anteriorly. This one comes anteriorly. You are not able to see the anterior rib up to the sternum because there is a cartilage. There's costochondral junction. A cartilage is not visualized on a radiograph. It's a soft tissue. You cannot be able to visualize. That's why, you know, these ribs, you see that they're terminating here. These ones are terminating here. So that's how you follow the ribs. Someone asked the mitral valve replacement. So this is a patient who had rheumatic heart disease. You can be able to see the coronary is plate. He has a double heart border. This patient underwent surgery, and this is a replaced mitral valve. This round thing is a replaced mitral valve. The other thing you need to look at, this patient has some features of pulmonary edema. Normally, the upper pulmonary vessels are smaller than the lower ones. Once you have the upper bigger than the lower ones, then you have something called cephalization of pulmonary vessels, which is a sign of pulmonary edema. What was the other question? I'm trying to remember. Daktari, what was the other question? Sorry,
There's a
can
question
check it.
on, please, could you explain more on Kali lines?
Yes, so Kali lines are many. So you have Kali A lines, you have Kali B lines, you have Kali C lines, you have Kali D lines. Normally, the lines that you see on the what is it called? On a radiograph are bronchovascular markings. These are vascular markings. But then if you have lines that go, you know, horizontally, which are thin lines, I mean like thinner than the vessels, and then they appear horizontal, they're usually not so long, they're usually around 1 centimeter or 2, you know, in the periphery of the lung. Okay? And then Kali B lines are usually perpendicular to the pleura. So if you see a dense line that is, please don't confuse with the normal horizontal fissure. In some people, it will appear there, some people it will not appear. But then when you look at mostly it looks at the bases, then it looks perpendicular to the pleura, just a thin line that is perpendicular and it's brighter than the vasculature. In the right setting, those are Kali B lines. Then you have Kali A lines. Kali A lines are usually oblique. These ones are horizontal. Kali A lines are usually oblique. They feel like they're radiating from the hilar, heading to the sorry, they're coming from the pleura, coming to the side of the hilar, they're oblique. They're also thin. They're a bit longer than the Cali-B lines, around 3 centimeters, but they're obliquely oriented. You need to differentiate those lines from the vasculature. They're usually brighter than the vasculature. I think Cali-C and Cali-D lines is what is it called? A variation of B. Cali-D is a variation of Cali-B line, but it's seen on the lateral radiograph, not on a frontal radiograph. Okay. Are we okay with the Cali lines? What you need to know is the Cali-B lines, mostly in patients with heart failure. That's the one maybe they can show you. If they want to pin you down, I don't know. Yeah, that's for Cali lines. Any other question, Dr. Maybe in the chat box.
There was one about, please, can you say something about silhouette signs?
Yes. Okay, let me go to a normal. So normally the structures are outlined by air. Okay. The structures of the mediastinum are outlined by air. Whether it's the mediastinum, whether it's the diaphragm, whether it's the pleura. So when you have ideally the sign is not to tell you like silhouette sign like is a sign of a pathology. It's like it's like a misnomer. When you lose the normal outline is when now that sign helps you, like you have lost the normal silhouette sign. Like let's say this is the right cardiac border. You have maybe a collapsed, middle lobe in the right, or you have an opacity that's obscuring the right heart border. That means then you can be able, in your description, you can say there's an opacity in the right middle lung zones that leads to loss of silhouette of the right border. Like silhouette sign is ideally a normal thing, unless you lose it, which you describe it as a loss of the normal silhouette sign. Okay, the same way goes to the diaphragm. Always make sure you're able to outline the diaphragm. Sometimes patients who have whether it's a lower lobe pneumonia or whether it's a collapsed lower lobe, you'll not be able to outline the diaphragm. So you need to know that the silhouette is a normal thing, silhouette sign is a normal thing. Unless you lose it, then it becomes an abnormal thing. Thank you. Any other question?
Yes. Someone is asking, how can we differentiate between mitral stenosis and regurgitation from X-ray?
You can't on X-ray. That is, that one has to be differentiated on echocardiography, but there are some indirect signs that can help you. On the radiograph. They are indirect signs, but it's just suggestive. It's not definitive. Then both of them will have, the left, what is it called? The left atrial enlargement, which will give you those playing and those things, the right heart border. I mean, common things appear more commonly. The mitral stenosis appear more common than mitral regurgitation. But then if you look keenly, mitral regurgitation are usually associated with cephalization of the vessels on the right heart side. Sometimes you'll feel that the vessels on the right lung, sorry, not right heart side, on the right lung, they are more cephalized than the left. And then you have cardiomegaly in addition to features of left atrial enlargement. Then you can be able to suggest that this is a patient who has mitral regurgitation. But then it's not definitive. Echo has to be done. That's why it's always, when we write those reports, we recommend, even if the patient has cardiomegaly. And then please, this brings me to the question, if you happen to have an X-ray and you think this is a pathology, but you're not sure what is a pathology, please don't stop that patient at that level. Take them to the next imaging level. Sometimes you might be the last person to see that patient. There are cases where a patient has a malignancy, mostly in the periphery. If they are done an X-ray, there are cases, there's something called round pneumonia, which appears in children. Then, but the round pneumonia, the masses, there is a thin line difference. So patient is treated, and then later on when they come back, massive effusion, then is an end-stage disease. Please, if you're not, if it's a direct diagnosis, if this pneumonia is pneumonia, even if you have, that this is left atrial enlargement, just send that patient for echo. If you have cardiomegaly, send that patient for echo. You never know what might be found, so that at least the patient gets help and managed appropriately. I think that will also help you become a better doctor, and at least you help the patient.
She has shared a question from a past paper that was done. Can I share?
Oh no. All right, just share.
Okay.
Do you guys do radiology?
I'm in third year, so I'm not doing it yet. The other classes.
I mean, like, are you guys tested like radiology in the final exam? Sorry, I failed. Not I failed. Sorry, that's a bad one. I'm sorry, I did not include a picture of miliary TB. I think in your reading, please just have a look, especially for the guys who are finishing. I got a miliary TB case in one of the OSCEs in my final exams. So please have a look how a miliary TB looks on a chest X-ray. But then these things are marked. Even if you say this is a radiographs of XYZ taken on this date, don't forget to say those things. They have marks. Each one has a mark, and say this is, AP or PA. Well, there is no rotation or there is rotation. Well ventilated, good exposure before you even go to the diagnosis. Okay. You might get half the marks, 5 out of 10, by just saying those things. And then just describing, you get another marks. And then if you don't know the diagnosis, I mean, it's not the end of the world. You'll still get your 7, 8. So don't forget to mention those ones. The biodata of the patient, you know, the technicalities, orientation, penetration, exposure, and then you go to the other pathologies. You have shared the X-ray.
Yeah. Is it visible?
Yes. So these are 23-year-old with dyspnea. I think now you can be able to give this diagnosis, huh? As I told you, common things more appear more commonly. This patient has a left atrial enlargement. You can be able to see there is a double right heart border. There is plane of the carina. There is cardiomegaly. Some bit of cephalization that is seen. Then the diagnosis comes. Is it mitral regurgitation or mitral stenosis? Definitely is not A, B, C. And it's not A, B, and E. You have to go to mitral stenosis. You know, put your bet on mitral stenosis. That is the most common valvular heart lesion that you see. Of all the valvular heart lesions you'll come across, mitral valve stenosis because of rheumatic heart disease is the most common. Okay. This is IMED. Okay.
Okay. Let me stop sharing.
So it's one of those, is it called what? The one that they project in the final exam. Is it spot for IMED? So you also need to know how the ECGs look, you know. Please don't forget those Tossard, I don't know, Tossard, the pointers, VTAC, how it looks. Those things come in the sports.
One last question. How do we differentiate between AP or PA-CXR?
The safest way is look at the scapula. If you know if any one of you guys ever did if any of you guys ever did a chest X-ray, if you're standing, you're told to hug that nini, it's called a baki, to hug that, so that the main idea is to separate, to move the scapula from the field of view. But then in patients who have AP, they cannot, move that. So that's why in patients who have AP, you'll see that there is what is it called? The scapula is seen, most of the part of the scapula is seen behind the lung. That is your safest way. The other way, because I'm trying to avoid telling you guys the gastric bubble, because it depends whether that patient fed or not. Because if the patient has not fed, you'll see a bubble. If he has fed, you will not see a bubble. The other one is the ribs. Are you seeing the anterior ribs or you're seeing the posterior ribs? Look at the orientation of the ribs. The posterior ribs are usually more horizontal. The anterior ribs are usually more vertical. Okay. I see one of our colleagues. The most common cause is mitral regurgitation. Okay. I don't know. I've stopped looking at those things. But the ones we see in Kenyatta, most of them are mitral stenosis. Actually, mitral stenosis, left atrial enlargement, especially in, around a 15 to 20 years old, most of the X-rays who have heart failures are because of that. But again, we don't put our reports mitral stenosis. We just say features of left atrial enlargement. Then they go look at the echo and find out whatever it was that is causing the left atrial enlargement. Any other question that I forgot?
I'm not seeing any other questions. So I think the session is coming to an end now.